very good evening and warm welcome, everyone. I, Dr. Ritika Dhiman, on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for today's discussion. Voice of Healthcare, along with our supporting partner Pfizer, has taken an initiative to bring together the experts and speakers to recognize Kidney Cancer Awareness Month. So, on our second session is on the topic improving access for treatment of renal cancer in India. In this panel discussion, we aim to explore the challenges associated with accessing treatment for renal cell cancer in India and discuss potential solutions to improve access for patients. So, without further ado, let's get started with the introduction of our esteemed panelist. I welcome Mr. Naveen Kumar, IAS, Special Secretary, Government of Uttar Pradesh. Welcome, Mr. Kumar. Dr.
Thank
Atul
you,
Batra.
Ritika.
Yeah. Dr. Atul Batra, Associate Professor of Medical Oncology, AIIMS, New Delhi. Welcome, Dr. Batra.
Thank you for the warm welcome.
Professor S. Venkataramanaiah, Professor, Operations Management, IIM Lucknow. Welcome, Professor.
Thank you, Ritika. It's pleasure meeting you all here.
Yes. Moving on, Ms. Jyoti Patil Shah, Chief Executive Officer, We Care Foundation. Welcome, Ms. Patil.
Thank you.
Dr. S.K. Raghunath, Director, Uro-oncology and Robotic Surgery at CG Cancer Center, Bengaluru. He will join us in a bit. So, starting with our discussion, I would like to ask first Mr. Naveen Kumar. So, how can we improve the screening and diagnosis of renal cell cancer in India, particularly in rural and underdeserved areas?
See, I was told that RCC contributes about 85% of the this particular cancer. That's I think Professor Batra is there and others are there who would agree with me. And suddenly, I also have this surprising number. It's not just the older lot, which is 50 to 50 plus or 50 to. I think there's a bandwidth is somewhere between 50 to 65, which constitutes about 40% of your thing. But surprisingly, it is also the younger lot, less than 20 years, which is about 14% of the this particular renal cancer, which means that I think it's something we are looking at less than 20%, less than 20 years of age, about 14% of the people suffering from it, and another 40% from this age group. So it's, I do not know. I think it must have strong scientific reasons to have such a differentiated numbers. I think the other experts on the committee would, the panel would talk about it. But I always think cancer as an disease. I think that's the what has happened in the recent time is we also have to think that any cost which the government has to put in, it will become a public health cost. So I think the mass screening is the only way to reduce and also save life. DILY numbers. You also look at this number is about
I think there is some connectivity
Bandwidth issue.
that was
issues.
working on
Yes,
how
there
to.
is some bandwidth. Yeah. Yes, he's back.
Yeah. When you look at when I think the Professor Venkat worked on a project called how to scale up the screening with OBC, oral breast and cervical cancer, which would bring down the cost of public cost on healthcare, right? So that is also very important. So we should look at it not just as an health economic factor, but also improving lives and saving this 20 the under 20 population. I think that's something which is very important. I think it could be taken up in schools and awareness is created. I think most of the children would not be aware that there is a possibility of RCC happening to them. So this could happen, and this is the way forward. I think mass screening is the only way forward to to reduce any burden of cancer on the society.
Yes, thank you so much, Mr. Naveen. I think he has rightly said that with mass screening, we are able to diagnose any disease, not just renal cell cancer, early, and early detection don't have much consequences, as compared to the advanced disease. Early detection is the priority should be the priority. So, moving on with this, I would like to ask Dr. Batra, what are the different type of treatment that are available for renal cell cancer in India, and how can we ensure that patients receive the most effective treatment for their individual needs?
Uh, Thank you, Dr. Ritika, for the question. So, if you look at the treatment of renal cell cancer, there are four stages of this disease. One is a very small tumor that is within the kidney. Two, again, a little larger tumor that is still confined to the kidney. Three, it goes a little nearby but not to the distant organs. And four, it's gone to the distant organs or has an extensive spread locally. So these are basically the four stages. If you look at stage one, two, three, the most important treatment here is surgery. And before a couple of years, that was the only treatment that used to be given, and there was nothing else that would help. But in recent years, last 1, 2 years, we have found that immunotherapy, if given after 1 year to a select high risk group, also improves the overall survival of these patients. And for stage 4 patients, there are basically two types of treatment. One is the oral drugs, which we call as the tyrosine kinase inhibitors. These basically target the blood vessels. So when a tumor grows, to understand this, when a tumor grows, it would need more and more nutrients. And for these nutrients to come, there have to be formation of new pipelines of blood. So these pipelines that are formed, these are called angiogenesis, right? And this is very, very important in kidney cancer. So if we can stop this blood supply by preventing new blood vessels to be formed, by inhibiting angiogenesis in scientific terms, we can prevent its further growth and can cause a little pause in its growth. That's the most important aim in stage 4 cancer. So this is achieved by several drugs which have been available to us, like pazopanib, sunitinib, cabozantinib, lenvatinib. So all these drugs act via this mechanism, and these have been very, very effective drugs over last decade. I think we have had the opportunity to use almost all the drugs, and also thanks to Pfizer's support program that it had provided free of cost drugs to BPL patients, and that has helped them a lot over the years. Now, coming to the second class of drugs, apart from these angiogenesis inhibitor, these are immunotherapeutic drugs. What happens is when cancer grows, it leads to the suppression of immunity so that immunity does not kill the cancer cells. Now, this new class of drugs that have come over last 5, 7 years, this removes this break so that immunity itself can kill the cancer cells. So it is not the drug that is killing the cancer cells. The drug is causing an increase in the immunity, and this immunity leads to a cancer death. Now, these have been very, very effective in renal cell cancer, especially in stage 4 and also in stage 2 and 3 for a limited time. The problem with these drugs, to give you the example of these drugs, this is nivolumab, pembrolizumab, avelumab. So these are three basically drugs that are approved as immunotherapy agents, also ipilimumab. And so these are quite expensive as of now. If you look at the Indian cost, the cost would be somewhere around 1.5 to 3 lakhs anywhere per month. For the oral inhibitors that we talked about, the cost is around 3,000 to 8,000 per month. So a big problem is the cost. And now hopefully nivolumab should be out of patent, or we should have first biosimilar by next year. The cost should come down. Also, there are several studies which have shown that a lower dose immunotherapy may also work, and as low as almost 1/6 of the prescribed drug may also be effective. And these are the measures that we have been trying to reduce the cost in the kidney cancer. So this is the brief overview of the treatment landscape. There are several other things, but I think if you understand these two classes, this should be good enough to take home today.
I think you have very wonderfully explained all of the therapeutic agents that are present today. Previously, we only had the option of surgery, and with the advancement in drugs and in the pharmaceutical industry, we have come up with such drugs, immunotherapy agents that you have explained right now. And you have said about the financials of it, that it's costly as compared to the Indian market. So moving on to that, I would like to ask Professor Venkat sir, what are the biggest challenges to improving access to treatment for renal cancer in India?
Yeah. Uh, Thank you, Dr. Ritika. Am I audible?
Yes, sir, you are perfectly audible, sir.
Yeah. So, having said by Dr. Batra and Mr. Naveen that the incidents are increasing and the cost of the treatment is one of the biggest challenges, and it is a very high cost. And since I come from supply chain and operations management point of view, and this cost is not in the hands of only one or two stakeholders. There are multiple stakeholders who are all responsible for this cost. Improving the professionally managed supply chains is the one solution. I'm not only talking about the challenges, because challenges are known to many people, but what are the possible solutions? I'll add a couple of them, then we'll move on to the next round. So one of the challenges is availability of drugs on a continuous basis, because these drugs requires continuously. During COVID time, you might have seen, and many others, that non-COVID patients, there are many people who have suffered a lot. The focus was on COVID patients, but non-COVID patients were equally struggled. So the point here I want to say is that how do you ensure the continuity of the availability of the drugs and the low cost, and also to avoid maybe due to because of the high cost, spurious drugs are also very high in the industry. You being from the industry, you know very well. So one of the biggest challenges is putting the supply chain in place to avoid these spurious drugs, and ensuring the drugs availability throughout the chain. And the government role is very crucial. And I would say, in the context of Andhra Pradesh, I come from Andhra Pradesh, and I have seen many people who have gone through the Arogyasri scheme and got the immense benefit, and including the treatment and diagnosis, and also the drugs. So unless you put these things in place, it's very difficult to contain. I think the role of government is very crucial. At the same time, the matching the demand supply. So demand supply is one challenge. High cost is another challenge, and making sure the availability of right drugs. I mean, genuine drugs, and avoiding the. How do you identify the spurious drugs and curtail them? So those are the some of the things to my knowledge, and maybe in the next round we will see what are the other challenges. Okay, so I'll
So,
stop.
thank you so much, Professor Venkat. So, I took 3 points from there that, availability of right drugs first, second is matching the demand and supply, and third is the public private partnership that,
Yes.
we can, yes. Thank you so much, Professor Venkat. So, moving on to Miss Jyoti Shah. Ma'am, how can we improve the availability and affordability of renal cell cancer treatments in India?
Thanks, Dr. Ritika. As Dr. Batra very rightly mentioned, that there has been access program for MRCC patients, and VCare has been a part of it since 2008. And these drugs were really a savior, and they were the patients called it a miracle drug because it really helped them in kind of taking over their disease, or because the drug was made affordable under the access program, they could take it into, and they could have these drugs, and it helped them. But it's like it's been the first line therapy, and I don't think there is another patient access program for any of the first line therapies that are there right now. And as we all know, cancer is not only does not take a toll only on the patient itself. It's like, psychologically and financially, it's the entire family. Now, when Dr. Batra did mention that these drugs, which are like currently in like immunotherapy or any other targeted medicines, are not less than a lakh, or anywhere to 3 lakh 4 lakh a month. So for 1 month's medicine is what they are looking to spend for, which is really difficult. uh, even for the middle income or the higher income, for families, it's not possible. So when these access programs are brought into place, I think these are the saviors for patients, and these do help. But it's also has to be when these drugs are developed, one has to be very country specific pricing, what I mean, as the market people call it. And a big request is for having more and more access program for all these targeted therapies, because they go a long way for patients. The expectancy of their life, or they look into a lot of like good, what do you say, milestones in their lives. And if you have the younger population who is getting getting diagnosed with cancer, kidney cancer early, naturally the whole lifespan is in front of them. And if this is going to help them in kind of giving them at least to cover up or look after their family for a few more years, or take care of the important decisions that they need to make in their life, it will surely help. And it's also I think having these access program, as I said, country specific pricing, and maybe more flexibility for the patient to purchase them even if they have to, rather than being very stringent about they have to buy these many cycles and then they have to come on the program. Because it's very very difficult. If you initially you need to buy certain cycles, it's not going to help, because the amount is not small investment, it's a bigger investment. Yeah.
Thank you so much, Miss Jyoti Patil, for elaborating that cancer is not just taken a toll on a single person; it's a family that is involved, and apart from that, not just their physical health but their mental, emotional, and financial health as well. It affects. Professor Venkat, discussed about private partner, private partnership. I would like to ask Mr. Naveen Kumar, sir, how can we encourage greater public-private partnerships to improve access to renal cancer treatment in India?
Yeah, I think Professor was also talking about Arogyashi, which is the country's largest medical insurance scheme. We spend about 3,000 crores every year and covering about 90% of the population in AP. One of the things which we could not do, I think it's time to we start doing it, is to empanel immunotherapies also into treatment protocols. I think that has not happened, but there is some effort being taken to get. One of the things which happens is that immunotherapy is only available to set a particular section of people, right? So we should make sure that it is affordable and accessible to everyone. So, and mostly it happens given the cost. I think it's not easily accessible and affordable by many people, right? So we should be able to bring treatments. I think that's one of the things which we should also look at when we are able to spend at least 5 to 6 lakhs per, in some cases of cancer. In fact, the AP government has also spent 30 to 40 lakhs in certain cases. We should also, press upon PMJAY to, take immunotherapies, maybe to only to the premier institutions like AIIMS, and these institutions should be given that privilege of, using immunotherapies under medical insurance scheme. This would bring a lot of people under the the scheme or the access to the immunotherapy, right? So this could be done. One of the other point which the professor was talking about is also the cutting the cost by efficiently managing the supply chains. I think the procurement by the central agencies in the state government, this also would help bringing the cost down. The third point was that I think it's IPR regime. If the IPR regime is there and the Department of Pharmaceuticals can look at producing these drugs within the country, I think this is also one way forward. Given this, I think I'm told about 3 to 4% of the population, of the total population, which are afflicted with cancer, is about as RCC. So, which means that it's a very good ground to start with. I think these are preventable. The younger population which is going to suffer from RCC can be given treatment. Different types of treatment, in fact, targeted therapies can also be given. So we should probably, what we can look at is uh, the producers of these medicines can tie up with governments through a special MOU and offer governments at a different rates to at least to build confidence into the system, to talk about how immunotherapy can even be accessible by the poorest of poorest in the society. This would also bring a lot of confidence into the system. In fact, I'm not. It's very few people are aware of immunotherapies and also avail immunotherapies, right? So which is also an impediment to scale it up in the larger population. So we should also look at different solutions. So I see the collaboration between the public and the private would also lead to, creating newer protocols, newer, treatment protocols, and giving access to everyone. That's my take on it.
Yes, Mr. Kumar, you have very rightly pointed out the significance and importance of public-private partnership to improve the access to renal cancer treatment in India. And moving on to that, Dr. Batra, how can we promote greater collaboration between different stakeholders, including the doctors, patient advocacy groups, and government agencies, and pharma companies to improve access to treatment for renal cancers?
I think this is one area where we haven't worked much over the years, and because cost, we never expected that cost of cancer care would reach to this these numbers, and it would practically be impossible. So even for a middle class or a high middle class, it's almost impossible to pay out of pocket, right? So there has to be some kind of partnership in terms of either insurance things, medical insurance coming, which is a co-pay by the government or co-pay by the individual, depending on the financial status. For the government to take take up, I think they have taken up PMJ in a good way, but I think it's mainly for very basic treatment that covers it. It's just 500,000, and with the cost mounting up, that would just, I think, suffice a couple of cycles of most of the newer treatments now. And there's almost a lag of a new drug from getting a good result in a clinical trial. For it to come into India, there's already a lag of, say, 3 to 4 years now. It has now reduced, I think, with DCJ also being more active, it has come down. But even after that, the cost is so high that when we have done like studies looking at what is the access, it's almost less than 10% of the patient population that receives this kind of treatment. There was a study from Tata that looked at the penetration of immunotherapy. So, looking at all the patients who would be eligible and who actually received, I think the number was less than 10%. So, there's a huge unmet need, and we would need kind of innovative ideas here. It's not going to work in a singular, single way flow from the government to the agencies. I think none of the governments would be able to take out this much amount of money with this kind of population and the cancer numbers rising like anything. So we need pharma companies to also kind of step in and look at how soon can we be producing once the patent is over. Like to give you an example for palbociclib itself, I know it's against Pfizer, but uh, so before January, I think 15th or 16th this year, the cost of palbociclib per month was around 75,000 a month, right? And when its patent got over, the next day on 17th of January, it came down to 3,000 per month. So that is the kind of power that our Indian pharmaceutical companies have with generics. So nowhere across the world would this cost be available for this kind. But the problem is the patent period. So what do we do during that? How do we access that? So this is where I think partnerships between the government and the private insurance companies in some way, and then bringing more and more clinical trials into India, wherein patients can participate into clinical trials and then get some benefit through that as well. So those are things that can be done. And from a scientific point of view, there are many drugs that have been shown that like for previous drugs, it used to be the maximum tolerated drug for chemotherapy. Like you check in trials, how much can a person tolerate? You give that amount of chemotherapy. But now, even the newer therapy, they don't need that kind of dose. So there are ongoing studies. Again, there was a study published from India only, where one-sixth of the dose of immunotherapy was good enough. I mean, so we also need to look into such ideas, because for this larger problem, we'll need a multi-pronged answer. We'll need innovative ideas on all fronts. So we need to start our own investigator-initiated trials to look at what would happen, and this would again need more funding on the from the research side. so that we look at what is the optimum dose for patients, whether a one-sixth of the dose would straight away bring down the cost by a big chunk if you look at the impact on public cost. So I think those are several ways where we can look at into it, and it would need a lot of brainstorming from all these stakeholders, the scientific team, the government, the insurance companies. How can we move towards a single direction of improving access to all these costly care? And with time, the cost is only going to increase. Like for now, we have been seeing drugs in the range of 1 to 3 lakhs per month. I think with future coming up, it's gonna further rise to 5, 7, maybe even 10 lakhs per month. We have some drugs that are being imported at such prices now. So
Yes, I think you have rightly mentioned that each and every stakeholder or a player in the healthcare industry has to play an important role in this to bring down the cost, to provide the access and the affordability, such as Miss Jyoti has also mentioned the patient access programs that the pharma companies are doing. So it's not just for one person or a one stakeholder to take a step. It's a multi-directional and multi-focal area which we can look at, whether it's a scientific intervention that can be done or from the government or from the insurance companies. So yes, you have rightly mentioned that, Dr. Batra. And moving on to Professor Venkat, sir, what role can telemedicine and digital technology play in improving the access to renal cancer treatment in India?
So it's again a very interesting question. And in fact, I will start with the how this telemedicine has changed the way the industry as well as the governments and the society by and large has changed during COVID. Even I wrote an article saying that it's COVID is a prescription for change. I put a question mark. Is COVID a prescription for change? According to me, it is yes. So this COVID has led to the adoption of not only telemedicine technologies, including unknown. Almost everybody became aware of what is health. Let me also share one anecdote here. Entire world came to know that what is the role of supply chain. Number one. Number two, how crucial is the health, either rich or poor or whoever it is, there nobody was spared during COVID and in particular wave two. So including my family, have gone through that, and telemedicine was the biggest remedy for that. The biggest remedy, if at all, if we say that what part of the treatment or the mechanisms that have saved the country and the world is precisely the telemedicine. There is no second thought. Earlier, people were thinking that it is difficult, that is difficult. Even industry stakeholders were thinking that, this will not work. This is health. It can work in some other field, not in health and all. But health is the first one to adapt telemedicine or tele technologies. I'll give a couple of incidents with whom we are working. There is a startup company in started in West Bengal, and of course now it is available in different parts of the country and outside the country. They have used and they trained a lot of these children and community health workers on the use of digital technologies, including telemedicine is one of them during the this COVID crisis time. So there is no substitute. But one thing one has to remember here is, for many diseases or many treatments for that matter, at least once in a while, a physical visit is very, very essential. And this is going to improve the health, access and affordability significantly, very, very significantly. So my point here is the startups in healthcare, neither government nor pharma companies nor medical companies, all of a sudden, the IT startups are, I would say, digital startups are disrupting the healthcare industry in particular through this telemedicine and teletechnologies. And in fact, we wrote a simple article and it got published also. I'll share that with many of you. Of course, it is there on the overall, open access also. And there are multiple platforms on which this telemedicine has to be strengthened. This is one thing. And it will connect to the previous question about collaboration. Today, the order of the day is, not a friend with whom I am going to collaborate. It is, other way around. You have to collaborate with someone who is your competitor. So in our language, it is called co-optation. Cooperating with your competitor is called a co-optation. Okay. So precisely, you need to do this or put this into practice, and the role of government is very very high in making this realized. How to bring various stakeholders to work together. You call it as collaboration, you call it as public private partnership, whatever it is. There should be a properly aligned, I underline again, not misaligned, properly aligned incentives for everyone to come together. I'll quote one another small anecdote here. Arvind model, and you can even watch the video, TED video by Pavitra Shanai, and she very aptly said, long time back, not now, we are in the business of training competition. We have to train the competition actually. So that is where the crux is. And health is, it's not a competition. Health is a welfare, and the role of every player is to make sure that the society is moving towards the healthy society. So telemedicine is one of the, I would say, the first steps towards improving all dimensions of healthcare, including access, afford, quality, and maybe including satisfaction, etc., etc. And today you can't reach out to many places, but you can still, smartphones. It should be like a mobile phone. So today, a lot of doctors are responding to their patients not by calls, and rather WhatsApp. I don't know how to classify WhatsApp, but WhatsApp doctor, and including me, I'm putting a message to my doctor friends that this is the diagnosis report. What should I do? Sometimes I write this to AIIMS director. My friend happened to be AIIMS director, Dr. Ajay, and he says, "Hey, Venkat, you don't worry. These are all normal. You continue to check your, health parameters, but don't be worried. But it's good that you are asking. That you don't need to be very very skeptical about these things, and in particular for cancer." And physical treatment, physical consultations will be very very costly. These can bring down the cost. I don't. I think even 1/100th, both for the doctor as well as for the patient. And also, this technology, you don't need to answer immediately unless it is emergency. Many a cases you can address even after some time. If doctor, before going to the bed, if she or he can respond to their patient that everything is fine, I think they will be very very good. And I would say, with the communication, continuous communication with the patient and doctor or the stakeholder will be the biggest medicine for these kind of things. I think there is a behavioral aspects also attached to this. This can shape up completely different. This is my take on that. I'll stop here. Thank you.
Thank you so much, Professor Venkat. So just bring brought those memories back regarding COVID. So I also had COVID in the second wave, and we
Very
had a huge responsibility of delivering the vaccine, the demand and supply chain that you told about. And I think after that, healthcare got a boom. So I call it as era of healthcare now, because people really got into their health and talked about health, for that matter, which was not discussed previously. And now they are taking care of themselves. And after that, the technology was integrated. Before there also there was integration of technology, but the expedition of technology we saw after, or even in the times of COVID. So yes, so we have Dr. Raghunath here with us. Hello, sir. Good evening.
Hi, good evening, madam.
Yes, sir. Sir, as you are here now, so I just want to ask you, so how do you see the treatment landscape for renal cell cancer evolving over the last few decades, and the role of precision med and technology in that?
So I would talk first about the systemic therapy options. When I was a student, all these tyrosine kinase inhibitors were not there. Immunotherapy was not there. So we were just uh, interleukin 2 was available. High dose interferons, I mean, interferon 2 was available. High dose interleukins, I've never seen that. So that has transformed later, maybe one and a half decades back, into availability of sunitinib. Then all these tyrosine kinase inhibitors with better efficacy, with lesser toxicity came, and now we have moved on to availability of immunotherapy. Various types of immunotherapies are there, and combinations are giving excellent results. So that has happened over a period of 2 decades. So now with the combination of tyrosine kinase inhibitors and immunotherapies, the results, long-term results are excellent. Okay, even at 24 months, we have seen more than 24% of patients, or 25% of one fourth of patients will not have any evidence of disease. Okay, so we have achieved these things in the recent past, and new trials with the different combinations are coming. And with the advent of understanding the tumor biology, probably we will be able to decide which treatment will work best for a given patient. So that is with respect to systemic therapy. When it comes to the technology, nowadays, this technology is predominantly utilized for organ confined disease, or even for small renal masses, what we call small renal masses, which we see in our practice. The person goes for ultrasound scan, which is available everywhere, for vague abdominal pain. Okay, when they detected with a small tumor in the kidney, maybe 3 centimeter, 4 centimeter in the kidney. So that is, earlier people used to do radical nephrectomy. Now we have changed over completely to partial nephrectomy, where we remove the tumor and we retain the kidney. These are several advantages. By retaining the kidney, the chance of development of chronic kidney diseases will be less. When they don't develop chronic kidney diseases, obviously the hospitalizations and cardiac risk, all those things will be minimized. So we moved from radical nephrectomy towards conserving the kidney. So how can we achieve this one? With the advent of robotic surgery, we are doing nowadays almost all partial nephrectomies, or kidney preserving or nephron sparing surgeries utilizing the robotic technology. The complications are less, and we can preserve better nephrons. So this technology has helped us, robotic technology. And now with the help of artificial intelligence and all, we can understand the tumor anatomy better, and we can do more nephron sparing surgeries with the advent of 3D imaging and other technologies. So this is what I would like to say at this point of time. This is how evolution has taken place with respect to organ confined and small renal masses and systemic therapies.
Thank you so much, Dr. Raghunath. You have very well explained what has happened in the past decade for renal cell therapies, treatment with respect to surgery, and plus the chemotherapy as well. With this, I would like to move on to Ms. Jyoti Shah. Ma'am, what role can the government and private sector play in improving, access and affordability of treatment for renal cell cancer?
Like rightly said that everything has evolved during COVID or because of COVID. There has been so many innovations. COVID, the vaccine itself has been such a bigger innovation for Indian market, because it didn't take much long and it came in the market. People were vaccinated, but I guess everybody was like, if COVID vaccine could come in, why not the other medicines? That was a bigger question that everybody had. So when everything had evolved, I think what has to evolve more is the insurance companies, because not all treatments need hospitalization, but still they have this mandatory requirement where the patient hospitalization is required. So why can't they have the change internally within the insurance policies, where they can include the oral medications which are not part of the insurance policies that people take. Like many of the panelists here know are mentioned about immunotherapy, about targeted therapy. None of these drugs are so easy to purchase or easy to take. Like even if today, if I have to put in myself, I will like, I know this drug is going to work for myself, but how am I being able to afford it, because it's so expensive? I mean, can I think of spending 4 lakhs a month for myself when I have my other family members who need to be looked after? And this is a concern not only for me but everybody of us who are here. So I don't know how, but I think a lot many things can be done if insurance companies can come up and say, okay, not the full I mean, not the full benefit, but at least some partial support can be extended to these oral medicines or to the immunotherapy treatments options that are there. Similarly, at the same time, the Ayushman Bharat program has been taken up by many of the states very beautifully. There are been inclusions of therapies after the patent or the generic drugs. I know, I mean, certain patented drugs need to go into it, because it will also help not the people who are catered to the AB program, Ayushman Bharat program. Because if I'm talking about the middle income and the a little higher middle income who cannot afford, I'm also coming for people who fall into the lower income or the below poverty line category. Well, a few access program, as I said, they are there, but not all. And again, if government can get some, I mean, something like AB scheme, what more can be done? Because it's like 5 lakh a month, 5 lakh a year package. But then what if one person is availing the 5 lakh? How does it help with the other family members who are there? Similarly, when we talk about clinical trials, the Asian population is not very included into the clinical trials that happen. I mean, we every time make a lot of noise that we need to get more access to clinical trials, but we need to be told that these are available and make a part of it. Because once the clinical trials are done, actually they are open for everybody across the globe to purchase, but the selected few are the ones maybe from the western zone who are there on the clinical trial. But then I think that inclusivity for the Asian population or the Asian continent needs to be there. So these are a few things I think people. I mean, and we all are here for patients. We are all here to make it more easier for them who are already going through so much. So maybe yes, collectively working together. In whatever way possible, helping each other in sailing through those things, coming up with solutions. We know there are going to be problems, but those problems need to have solutions. So let us think a little ahead and see what solutions we can come up to, because we know this is going to arise somewhere down the line. So I think that needs to be addressed. Yeah.
Thank you so much, Ms. Jyoti. You have rightly pointed out the collaboration that we need to do. There will always be challenges, but we need to focus more on the probable solutions of what can be done. So, with this, Mr. Naveen Kumar, I would like to ask you, sir, how can we leverage existing healthcare infrastructure and resources to improve the access and affordability of treatment for this cancer in India, renal cancer in India?
Yeah, so I always talk about this particular point. Given any single point of day, about 1 lakh of people are accessing public health care, be it a government hospital, be it a tertiary hospital, or be it a CSC or a PSC or a wellness center. So how can we first, in the first place, we can create an awareness, tell them like how would RCC would look like, right? The first stage one, what is the 2 or 3 questions which everybody can be asked about. I think this would work for every kind of cancer. In fact, there are algorithms which are there to stratify the risk and find them and bring them for treatment. The second is also to build capacities within this organization. For example, there are newer technologies, newer therapies which are coming, and I think the government hospitals. I would talk about the public healthcare system. So the government hospitals should be also updated as and when the newer technologies are available and also the therapies are available. So these would be two things, and then I think this would build at least for the basics for a good response to the system. The third is the supply chain management. It's purely an administrative thing, so this could also help making the better ground on it. So I think these three things are the main key parameters, and we also have to go about screening. But do we do a mass screening for it, or stratify the risk and find out these are the population? There are populations within the state. We have chronic kidney diseases in certain areas of Andhra. So these are questions which we can look at, probably take them for first round of screening, second round of screening. But mass screening is the way forward. You can't leave anyone left behind. So it's important that we have to go about doing mass screening, educating people, and I think the first A of healthcare starts with awareness. So I think awareness is key, and we need to talk. I think that's more important. I do not know the we have a very strong response to these RCC now at the bottom of the pyramid. We could think of it at apex centers, but do we have this kind of response, the kind of response we are looking at the bottom of the pyramid? So we need to create a lot of awareness over it. So I think this would happen only when there is a collaboration between private, public, and a lot of interest groups coming in, talking about it, building capacities, and training people. So these are way forward.
Thank you so much, Mr. Naveen Kumar. I think you have rightly pointed out that there are things that are available, and people doesn't have access to those because of lack of awareness. Towards it. So yes, so moving on to that, as Miss Jyoti has pointed out that we don't have access to much. There are clinical trials, but the Asian population is not included in those trials. Dr. Raghunath, how can we learn from those other countries that have successfully improved access to treatment for renal cell cancer, and how can these lessons be applied in India?
One genomic studies are not available widely in India. Probably these are available only in selected centers, selected private centers. So probably with the help of government and NGOs we can bring in this fund, so who are going to benefit from these things. And many immuno-oncology drugs are because of various reasons not available or not affordable to our Indian patients. So government probably should do something uh, to bring down the cost at the government level. So these are the ways where affordability should not be a challenge for Indian patients. And who are going to benefit from that? Probably clinical trials are going to throw some light on Indian patients, because all these trials predominantly are done in the West. Though a couple of our Indian centers are also part of the global trials, but number of patients enrolled into those global trials are relatively less. So we will have India specific genomic data, and when once we get that one, probably we'll be in a position to tell which patient is going to benefit from what. So these things should be available to common man. Then it is possible to give the right treatment to them.
Thank you so much, Dr. Raghunath. That was very well, put into light that we need, if there are studies that for Indian patients are there, so there will be more clinical trials, more studies can be done, and accessibility of treatment can be done for that. So with this, I would like to conclude this session, by asking each of the panelists to share a 2-3 liner message. So we'll start with Dr. Atul, Dr. Batra.
I think in cancer, awareness is the most important key, and early diagnosis and meeting the earlier it is diagnosed, the better it is. Then we would less commonly talk about the accessibility to drug and everything. So that's my message: stay healthy, stay fit, and don't ignore any symptoms.
Thank you so much, Dr. Batra. Moving on to Professor Venkat, sir.
See, I'm a very big fan of these kind of short answers. I think collaboration and collaborative supply chain, I would say, is the very important thing. One thing I'd like to convey earlier, yeah, instead of public-private partnership in the healthcare delivery, I think we need a very strong public-private partnership on the supply side for research, medical research, as to be come forward for a very strong collaborative research. So I would say collaborative innovation is the way forward to answer the entire healthcare, not only cancer care, but the entire healthcare.
Thank you so
Collaborate.
much,
Yeah.
Venkat. Moving on to Dr. Raghunath, sir.
Yeah. So, as Dr. Atul said rightly, creating awareness is very, very important. And it should be like every person after the age of, say, 35 to 40 years should get one ultrasound scan done. Screening should be done. It's very easy to detect renal tumors in a very early stage just with simple ultrasound examination, which should be available at most of the places, which is available, in fact, which is very cost effective. It hardly costs 1,500 or 2,000 rupees. Every yearly once, or even once in 2 years, probably we should be able to detect these things, and it is potentially curable if we detect in a first stage. And if we detect this one, probably renal cell carcinoma related mortality should come to closer to zero. I would not say zero, closer to zero. So it's all our collective responsibility to, bring these kind of policies by having collaboration with the government and private organizations. So we should be doing this awareness and early detection using ultrasound simple scan.
Thank you so much, Dr. Raghunath. Yes, moving on to Ms. Jyoti Patil Shah. Ma'am, would you
Yeah.
like to say two, three
Yes,
liners?
I agree with both the doctors on the panel, where they say awareness is the key to everything. I mean, the more aware you are, the maybe the lesser, the disease, because preventive oncology departments are there in the hospitals. And every year we do go for every month, people who have BP, sugar, they do go for their blood test. So it's as good as going for your yearly checkups every year for these tests, which are all, easily available at the tertiary care centers or at the private centers, wherever they are comfortable in. And as Dr. Professor Venkat also mentioned, a collaboration, because we all are here, as I said, for patient care. So whatever way we can collaborate, whatever way we can work together and bring that little difference, make that little difference in the lives of patients will go a long way. I think that is what we all need to do.
Yes, thank you so much, Ms. Jyoti. So, with this, I conclude this session. I would like to thank all the esteemed panelists for taking time for this critical panel discussion today. This discussion has been very informative and has provided very valuable insights into this critical issue. Thank you so much for taking time from your busy schedule to be here. Thank you so much.
Thank you for
Thank you.
having us.
Thank you.
Thank you.
Thank you.
Thank you. Thank you, everyone in the panel, and thank you.